Hello everyone and welcome to today's Connect and Learn webinar, supporting young people with co-occurring substance use and BPD complexities. I'll begin today by acknowledging the traditional owners of the land on which we meet today and pay my respects to elders past, present and emerging. I extend that respect to Aboriginal and Torres Strait Islander peoples here today. My name is Rebecca and I will be facilitating today's webinar. This webinar is a part of a series of Connect and Learn webinars designed for AOD clinicians throughout Victoria. However, we welcome all of our interstate viewers. This webinar series is funded by the Victorian Department of Health and hosted by Turning Point. We like our webinars to be interactive, so please do ask questions via the Q&A function. The questions will be collated and answered by presenters at the end. We encourage you to stay to the end of the webinar and complete the QR code so we can evaluate our webinars. A copy of the slides will also be emailed to you on this occasion. I'd like to introduce our presenters, Dr. Zoe Gibbs and Mr. Peter Smith. Peter is an ACT therapist and educator at Spectrum. He also works in private practice and engages in secondary consultation in the Personality Disorder Initiative. Peter is an accredited mental health social worker with many years' experience in a variety of contexts and roles, including more recently in public mental health outpatient clinics. Zoe is a senior clinical psychologist at Spectrum, where she provides DBT for adults, young people and their families. She's been with Spectrum for several years now, where she specialises in complex PTSD through a DBT framework. She also has a particular interest in working with BPD in a youth population. Zoe has experience both in Australia and overseas. Thank you and welcome to both of you.
So welcome everyone. As Rebecca said, this is supporting young people with co-occurring substance use and BPD complexities. And here I am. Before I go any further, I'd like to acknowledge those with lived experience. So we acknowledge people with lived experience of mental ill health and recovery and the experiences of those who support them, including carers, families and supporters. The voice of people with lived experience informs our work. We recognise the vital contribution of lived experience at all levels and value the courage of those who share these unique perspectives for the purpose of learning and growing together to achieve better outcomes for all. So the learning outcomes for today's session are fourfold. Firstly, to build an awareness of the co-occurrence of and risks associated with substance use and BPD in young people. Secondly, an introduction to an adapted dialectical behaviour therapy approach to working with young people who have both or who live with both a borderline personality disorder and substance use complexities, and then a brief demonstration of how to incorporate the DBT practices into existing treatment service provisions. And hopefully at the end, an opportunity to share experience of what works, both in terms of what we've delivered through Spectrum and also potentially through the Q&A if you have some insights and contributions. We welcome those too. Just a quick word then too on the style of today's presentation. I will be delivering the first half, and in that first half I'll be looking at BPD and substance use in young people. And the second half you'll meet with Zoe shortly and she'll go into detail about the adapted dialectical behaviour therapy for substance use disorder approach and how you might be able to embed it in your practice, in your work contexts. So, building off the research conducted by Origin Youth Health here in Melbourne, and as you can see referencing here, an excellent article, which is linked to at the end of this presentation in the Journal of Personality Disorders. We're aware of a very significant prevalence of substance use for young people who also have a diagnosis of borderline personality disorder. So when we're talking about young people, we're talking between the ages of 15 and 25. And the research, that particular research shows a very, very high prevalence of both concurrent substance use disorder of some description and a borderline personality disorder. As you can see here, 20% of young people use alcohol, 63% using nicotine on a daily basis. Monthly use for marijuana is about 44%, A monthly use for amphetamines, so we're talking ice and speed, 17%, and a complicated mix of various different substances use monthly plus, so more than a month, up to monthly, is about 21%. So when you look at all those figures, we're looking at extremely, in some cases in particular, especially with nicotine, significantly higher rate of use than in the general population. So it's a bit of a very clear health issue here, and a confounding mental health issue here for people with with BPD and young people with BPD and substance use. Now, of course, it's really important if we want to do good, effective work with anyone when it comes to substance use, we need to understand what their reasons for use are. And we know that for substance use in a youth BPD context, then those uses turn on, perhaps unsurprisingly, given how borderline personality disorder presents as emotional instability, then a strong motivating factor for substance use is the management of very strong and very difficult emotions. So people with BPD often haven't had the best opportunities to learn how to down-regulate their intense emotions. And substances can be a nice, convenient, effective shortcut in the short term for that. Of course, there are longer-term gains with emotional disturbance that come with many substance uses as well, of course. Perhaps unsurprisingly then too, where BPD indicates disturbance in a sense of self, a sense of relationships and personal efficacy, interpersonal efficacy, then peer acceptance is also a strong contributing factor. And of course, we know that for young people, especially in their teen years, where identity formation is really foremost, peer acceptance is a very high motivating factor for a whole range of behaviours too. And so it's unsurprising then, if somebody has BPD and they're in their teens, there is a strong, strong drive to be accepted with one's peers. And if those peers are using substances, unsurprisingly, the young person with BPD will begin to do that as well. In some instances then too, the use of substances is a form of non-suicidal self-injury. Another term for that is deliberate self-harm. We prefer to think of it more descriptively and less judgmentally, though, as non-suicidal self-injury. And what that indicates then too is people are using substances, young people, in these contexts as a form of hurting oneself, as a form of managing those strong emotions through that self-harm often, and sometimes as a form of communication as well. So it can be difficult to express verbally what's on one's mind and what's on one's heart, and the use of substances in a self-injurious way can be a means of doing that. It can demonstrate the person is living in a very difficult mental and emotional frame of mind. Similar and related to that is risk-taking behaviour as well. So people can engage in a way that is often born of low self-esteem that puts their life in jeopardy in different ways. It's a way of feeling alive. It's a way of feeling like one has some sense of control. It's a way of feeling better about oneself in the short term, whilst unfortunately leading the person to occupy a circumstance, a situation of high risk. So we know then too that substance use can contribute to all kinds of difficult secondary behaviours around very dangerous types of undertakings and or miscalculation of various undertakings too. So it can actually have a very bad effect, as you'd expect, on people's well-being and longevity. And unsurprisingly then too, then the pure sensorial experience of using substances can be a high motivating factor for use as well. So seeking highs, seeking different sensations and experiences. So when we think about how we support effectively with people, how we work effectively with people using substances, we need to make sure that we have a good grounding, good understanding about what their individual, specific, personal motivations, their own reasons for use are, if we want to be effective in our support to help them gain more control over their use. The risks associated with substance use for young people are very significant, and they complicate factors, especially when borderline personality disorder is in the picture as well. So we know that The more severe somebody's expression of BPD is, the more symptoms of BPD they have. Often then too is the greater the substance use. And with that it comes an increase in related risks. And those risks are additional mental health disorders. So the substance use might contribute to depression, may contribute to various psychotic phenomena. And so there's a high incident of co-occurring mental health disorders in addition to the BPD that are further compounded and complicated by the substance use disorder. What we know too is that there is a reduction in how able and effective and meaningfully the young person will engage with the mental health supports on offer. If a person is focused more on servicing their addiction, it makes the engagement and the priority for their engagement with mental health services far more profound and effective. We know that when people start using substances in their youth, they're more likely to continue on using substances throughout our adulthood. And so with that longer term use as well come further complications around a reduction in life expectancy, various kinds of physical health issues, the greater likelihood for overdose and death, and of course some of the psychosocial pressures around family relationships and financial pressures become more profound as well. So you can see it's a bit of a perfect storm, potentially, having borderline personality disorder and substance use disorder. Has long-lasting impacts on people's well-being, long-lasting impacts on their recovery, long-lasting impacts on their physical health. So the consequences, the utility of having this information is pretty significant. We know that it's important to address both substance use and the borderline personality disorder simultaneously where possible. We know that a dual diagnosis approach is usually the most effective. There is a kind of a symbiotic relationship really between borderline personality disorder and the substance use disorder. And we know that outcomes are better for each of these, both the substance use and the borderline personality disorder, if we support the young person to recover from both of them as best we can simultaneously. If it's only possible in your work context for whatever reason, even though the expectation is for dual diagnosis, but if it seems that for you, your role, your ability, your capacity is purely on the basis of mental health and working through borderline personality disorder complexities for the person, we know that that is more likely to result in the substance use coming under control, but not the other way around. If we focus purely on the substance use, it's more likely that the person will remain, even if the substance use resolves, that they still will remain with the mental health complexities and concerns and difficulties around their borderline personality disorder. So the next best thing, if we can't work on both simultaneously, is certainly to work through the BPD with the person and support them in that recovery. The exception to that, of course, is where the substance use is particularly life-threatening and or treatment interfering with the attempts to have their BPD resolved. If that is the case, then we really need to ensure the person loses their physiological dependence on their substances so that they'll be in a better position to enact the sort of life-affirming, recovery-seeking behaviour and intentions around resolving their BPD. So we know that when it comes to working with young people, that there is a very strong relationship between, and I guess this is true with everyone really, between mood instability and the substance use cycle of sort of building up to the substance use, procuring the substances, using them, having the experience that substance use brings in that moment, and then the inevitable calm down or withdrawal cycles. So with that, you'll expect to see a range of different mood swings. And of course, with BPD as well, there are strong shifts in mood. High lability is the norm for BPD. So you can see that there is a great complexity in the relationship between the BPD, the substance use, and mood here. And of course, a big driving force within all of that will be the person's substance use. Simultaneously too, we know that with BPD, frequent conflict relationship is a significant feature as well. And so where somebody is using substances, this can increase stress and conflict within relationships in addition to the borderline personality itself. We know that it increases a sense of impulsivity, unpredictability, and hampers their capacity to soothe their emotions in a way that doesn't involve the substances. And with that can come some very profound, very significant non-suicidal self-injury. So there's again, a very kind of murky, complex interplay of factors here with that impact on relationships. So it's important then that we think about how we want to support and engage with young people, where we know that our relationship is going to perhaps fulfill a very similar function, or perhaps have a very strong association with various types of attachments. We can get caught up in those attachment styles in our relationships with young people. So we need to consider how exactly we present and how we factor into that young person's life, and what kind of emotional investments they have in that, and what kind of way does that relate to their attachments. Are they a secure attachment? Is there an insecurity? We know that with BPD, insecure attachments are kind of the hallmark, and we should expect then too that we will get caught up into that insecurity experience. That sense of safety needs to be very closely attended to in our practice. So what we can see then too is that maintaining a therapeutic alliance is going to be a big component of the work. And within that then is the need to support the person to consider the balance, the difference, the shifting between change orientation, supporting the person to rethink their relationship to their substances, and validation as well, supporting them to feel like they're not being judged and that we understand what's going on for them emotionally, what promotes the substance use, and what's underneath that with the borderline personality disorder too. So we should see very strong shifts in mood. We should expect frequent conflict relationship with us. And it's helpful if we view that relationship through a kind of attachment lens in the service of maintaining a therapeutic alliance. Of course, suicidal ideation is going to be very common then too. And it's important that we think about our capacity to be therapeutic when people are occupying high-risk states around suicide. This, of course, is very complex and difficult when somebody is frequently intoxicated. We know that intoxication increases impulsivity, increases the likelihood of intentional and accidental death. So it becomes a very difficult and high risk, high stakes engagement when we're supporting anyone, especially young people with borderline and substance use. So this is complex, difficult work and can be quite difficult and fraught for us as professionals. Fortunately, we have Zoe to help us walk through some of the minefield, and she's going to provide us a quick DBT primer and understanding of DBT for substance use disorder. So without any further ado, I will hand over to Zoe. Welcome, Zoe.
All right, thanks, Pete. So just to give you a bit of an overview of what I'll talk about today, in a very quick little snapshot, I'll give you a brief primer about what DBT is all about, and then talk a bit about some of the adaptations that we can make when we're focusing on substance use disorders. And hopefully there might be one or two things that you could take away and maybe put into practice straight away. So dialectical behaviour therapy, or DBT, it's a treatment that was created in the sort of late 80s, early 90s by Marsha Linehan in Seattle in the States. And it was developed initially as a treatment for women with chronic suicidal ideation and multiple complex problems, which she sort of later came to realize actually is talking about people with borderline personality disorder. So DBT understands the problem behaviours that we see for people with borderline personality disorder, so things like suicidal behaviours, self-harm, substance use. These are all attempts by that individual to manage what feels like a really intolerable emotional state. And often what we talk about is being sort of an emotional burns victim, where even the slightest comment or the wrong look from someone might feel excruciatingly painful for that person emotionally. Whereas for somebody else with intact skin might not even register that that's taken place. So DBT, it teaches skills to try and manage these intense emotions, and it's quite effective at that, and it's also quite effective at reducing impulsivity. And so early on, DBT was identified as quite a good fit treatment for substance use, given that a lot of people with borderline personality disorder have that overlap with substance use, like Pete was saying, and in and of itself, just as quite an effective treatment for people with substance use who don't have borderline personality disorder as well. So DBT is sort of based on a biosocial model for pervasive emotion dysregulation. And so that's what we're really talking about when we're talking about borderline personality disorder. You know, it's this sort of pervasive emotional dysregulation. And that comes about as a combination of an emotionally sensitive temperament. So we know that for people with borderline personality disorder, their experience of emotions is that they're much bigger, they are more easily triggered, and they last longer than for the average person. And that this is coupled with an invalidating environment. And so that can mean lots of different things. So it might just mean a sort of a poor fit between our emotional temperament and the temperament of our caregivers, but it can also mean things like abuse and trauma, bullying, lots of really painful experiences where somebody learns that their internal experience isn't right or isn't understood by the people around them. And that this then leads to this sort of pervasive emotional dysregulation. And so when we're taking substance use into the picture, you can see how for all of us, if we use substances, that's going to make us much more vulnerable to having, strong emotions. I think most people can identify with that. And so, mixing those two together, you're creating bigger emotional experiences and more dysregulation. And then we also know that when you're substance using, it's going to create more opportunity for that invalidating environment. So like what Pete was saying, your likelihood of abuse, of being in dangerous situations, the difficulty it has in terms of your interpersonal relationships, people are getting angry at you, getting kind of kicked out of home, all these sorts of things, and that it just lends itself to further emotion dysregulation. So it kind of makes sense that for people who have both borderline personality disorder and substance use problems, that their dysregulation is bigger, that they're more at risk, they are harder to treat, and that their difficulties are more life interfering. So in DBT, the ultimate goal is to build a life worth living, and it balances this idea of acceptance and change. So accepting things the way they are, accepting that they shouldn't be any other way, and at the same time moving to change and to have things be different. So, the way that this really comes into therapy is lots of validation for people, lots of helping them understand their experience and communicating that it makes sense, and at the same time really pushing them to try and do things differently and to change that situation that they're in. And it does this through teaching lots of skills. So for your standard comprehensive DBT program, you're looking at about a year, and within that year, each week you've got an individual DBT session, and you're attending a 2-hour skills group each week. And you also have access to your therapist for skills coaching in between sessions. And these skills focus on teaching managing emotions, tolerating really painful emotions, so that's distress tolerance. A big component of mindfulness is sort of like the foundation skill that we need to have a level of awareness of our experience so that we can then think about what other skills we might need to use. And then also interpersonal effectiveness. So problem behaviours are targeted in an order of treatment hierarchy. And so because we know that, the people that we're seeing, they're coming with multiple problems, and it can lead to treatment becoming quite sort of confused. You might be focusing on, suicidal urges one week, and then the next week it's, I need to break up with a boyfriend. And then the week after that, anxiety might be the focus. And that can just lead to sort of, a lack of continuity, things get missed, and we're not able to create the change that we want. So in DBT, we have a bit of a way that we prioritise what we're going to be focusing on. And I'll give you an example of that in a minute. DBT also uses diary cards to track thoughts, feelings and behaviours, to track any problem behaviours that we've agreed that we're targeting. And it also uses chain analysis as a way to try and understand, the function of problem behaviours, what's reinforcing them, what's keeping them going, and gives us an opportunity to figure out, okay, what do we need to be doing different? How can we add in some different skills to try and help people change the behaviours that they're trying to change? So DBT and substance use. So I'll just show you, this is the DBT. Oh, you can't really see it properly. Just kind of. That's the DBT skills manual. And within that, built into the model, there's a whole section that has skills specifically for targeting addiction. And so a lot of what I'm talking about today comes from what you can find in the general DBT manual by Marsha Linehan. This is the second edition from, I think, 2014. So we know that just standard DBT will help people reduce their substance use. And there's also a couple of things that we can throw in. So I suppose one principle to bring into the work that we're doing is this idea of dialectical abstinence. And so we know that substance use programs that focus on abstinence only, so swearing off addictive behaviour completely, has some benefits, that people who take this approach stay abstinent for longer. But we also know that when they have a slip, it takes them longer to get back on track, and that it comes with a lot of sort of shame, and there can be more damage done in those moments where they fall off the wagon. And then if you think about harm reduction approaches, so harm minimization, we know that they're much better at managing when people do have a slip, that they get back on track much faster. But we also know that they can relapse faster as well. And so in DBT, we're trying to balance these two ideas. So we're absolutely going for abstinence only, no matter how brief that abstinence might be, even if they can only commit to being abstinent for that 1 hour that they're in session with you. That's always what we're going for. And we're also preparing and acknowledging that slips might happen, and when they do, being really non-judgmental, problem solving. We want to plan for these times to make sure that if you do slip, you know what you need to do, whether that's picking up the phone and calling your therapist, whatever it might be. And at the same time, we're aiming to be abstinent. So the other thing that Marsha Linehan noticed quite early on was that when you've got borderline personality disorder and substance use disorders, that the attachment style was slightly different. I suppose like what Pete was mentioning earlier, she noticed this tendency for clients to sort of flit in and out of treatment with little desire for strong attachments. So she called that butterfly attachment. And that this is a bit different, I suppose, from the clients that we usually see with borderline personality disorder with no substance use, who are much more motivated and reinforced by that relationship with the therapist, and they'll seek it out more. And so this can then result in a lot of problems with attendance and sort of falling out of treatment. So, thinking about clients that, they come for that initial session, they're really motivated, they come up with a really great plan with you, you're feeling really positive and about where things are going, and then you don't see them for 3 weeks, and then maybe they pop up again briefly and then disappear again. And so DBT addresses this really head on. So trying to, at the earliest possible time, working with that person to come up with a strategy for like, okay, if I don't see you next week, what can we do? How can we help you stay in treatment? And so this might be about, if it could be like giving them a phone call if they're not there, giving them a phone call half an hour before the appointment. It could be about saying, if you're not here and you don't answer your phone, who's the next person I should call? Getting friends or family involved in that plan, whatever is going to be effective at helping them be there in the treatment with you, basically. And it's also thinking about really understanding if they're not coming to session, why not? And really trying to be curious and understand what's gotten in the way. So, is it that, they'd used last week and they were feeling really ashamed, and so they didn't want to come and sit in front of you in session. And if that's what it is, then it's thinking about problem solving around that, reassuring them that you're not here to judge them, whatever it might be. It might be that they find the sessions too long. So saying, okay, well, the main thing is that you get here for the session. So if you can only do 20 minutes that day, that's fine. And figuring out for that individual what's going to help them be in treatment. Okay. So this is an example of a treatment hierarchy, like what I was mentioning before. So in DBT, we break things down into life interfering, therapy interfering, and quality of life interfering behaviours. And so the idea behind this is that if someone's passed away, we can't do therapy. Doesn't matter how good our therapy is, it's not going to do anything. So we are targeting anything that puts someone's life at risk as an absolute priority. And so obviously suicidal behaviours come under here, and substance use can often come under this category as well. It could be in terms of, an overdose, but also we know, like Pete was saying, that substance use is really related to self-harm and suicidal behaviours, and that often that will be a link on someone's chain. If there has been a suicide attempt, there might be substance use that sort of precipitated that. The next thing that we want to target is any therapy interfering behaviours. So anything that gets in the way of the treatment being helpful for this person. So like what we were saying before, like missing sessions, coming to sessions substance affected. So I've got misreporting or lying there. And so just a little comment on the term lying. That is something that this is a joint document that I'd have with the clients. We're agreeing on what's on this hierarchy. And so if they're using the word lying, I'd put down the word lying. I would never sort of accuse anyone of lying. That's probably not going to be so great for your therapeutic relationship. But, just having a really matter-of-fact conversation with people. Often they might have had therapy before. So you can say, okay, and why do you think that didn't work for you? Why do you think, it didn't hit the spot? What got in the way for you? And usually people, can be quite reflective, I find, and they can come up with some great stuff for you to work on together. And then the third category is quality of life interfering behaviours. And this is usually the stuff that people really want to talk about in therapy. And this is basically everything else that gets in the way of them having that life worth living, like what I was talking about. So, it could be unstable housing. It could be things like anxiety or depression, conflict in relationships, financial problems, whatever else. And so, and this is the stuff that you want to get to once you can be sure that there's no life interfering or therapy interfering behaviours at that time. So this is just an example of a diary card for someone, so sort of based on one that I used with someone who had substance use problems. But this is pretty standard DBT here. And so we're getting people each week to fill this out and to be reporting any sort of self-harm or suicidal behaviours, urges, but also whether or not they acted on them, reporting their emotions, reporting any substance use, anything else that we might be targeting. And so for this individual here, what we saw, you can see that there's a number of substances listed there that we're tracking, but there's also binging, purging, stealing. And for someone, it might be that there's this sort of like rotating set of things that people use to try and manage emotional pain. So they might be able to avoid using substances, but they self-harm a bit more that week, or they might, binge eat or whatever it might be. And so this is just a way of really understanding, getting a really quick snapshot of figuring out what's happened for that person in that week, helping them figure out any patterns that they notice, even just as simple as noticing, the impact that it has on their sleep when they're substance using, all that sort of stuff. So anyone familiar with DBT has probably heard of the idea of wise mind before. So this is standard DBT. And this is a really kind of key concept that we use, and something that we're always trying to activate in our clients is this idea of wise mind. And so the idea is that we all have a wise mind. Sometimes we're not necessarily talking to it or not listening to what it might say, but for all of us, it's there. And then we also have within us an emotional mind. And so this is, this part of us that's really driven by emotions, really sort of urge driven, very emotion focused, doing what sort of feels right in that moment. And that we also have this reasonable mind. And this is the part of us that's very fact-based, really sort of dismissive of emotions, doesn't take that into account. And that wise mind is the synthesis of those two things. So taking, I suppose, what we need from both minds and joining it together. So, the way I sort of often explain it to clients is, it's like when you go to the supermarket and you're in emotion mind, often that might mean that we're buying chips and chocolate and, junk food, whatever feels good in that moment. And then, of course, we've probably all been there. You get home and you've got nothing really to eat for dinner. You feel a bit sick. It hasn't worked out that well. On the flip side, going to the supermarket in reasonable mind, it's like, when you take your list and you're getting all healthy ingredients, and you've got these big ideas for all these, this meal prep that you're going to be doing. And then you get home and later that night, actually, you don't feel like doing all that cooking and you end up ordering Uber Eats. And so wise mind is taking into account that, we're going to want to treat ourselves later, that we might not always feel like spending heaps of time making dinner. And at the same time thinking, and I need to take care of myself. I need to make sure I have the ingredients that I need so that I can cook a meal later in the week. And so one of the adaptions for the substance use is taking that similar idea, but talking about clear mind. And so in this diagram here, you'll see we've got addict's mind. And so that's the part that just wants to use. It doesn't really have much motivation to not use. It's really, fixated on getting substances. And then we have clean mind, and that's when, people aren't using and they think, yep, I've sorted it out now. I don't have that problem anymore. I used to have a substance problem, but now I'm okay. I can probably have a glass of wine if I want one. I can take painkillers. It's fine. And so it's this part of us sort of oversimplifies the ease of not using. And so you can see how the getting stuck between that addict's mind and clean mind can create problems and can create this sort of like jumping back and forth between the two. And what we're really looking for with clear mind is this synthesis between those two. So you're clean, but at the same time, you're aware of the dangers of relapse and actively engage in behaviours to prevent that. So kind of awareness of your ongoing vulnerability. So I've got read out my little story here. So overcoming addiction is like fighting a long war against urges to engage in the addictive behaviour. The urges win a battle when you end up doing the addictive behaviour. And you win when, despite the urge's attacks on you, you don't do the addictive behaviour. Clean mind is forgetting the war once a few battles are over. It's thinking that because you've repelled the urges a few times, they will not come back, or that if they do come back, they will be easy to repel. When you are in clean mind, you don't prepare for battle and your defences are down. Urges can catch you unprepared and win. Addict mind is like being under siege by the urges and believing that you can never repel them again. When you are in addict mind, you don't remember your victories. When you are defeated, you don't regroup and fight back. Clear mind is remembering both your victories and your defeats, fighting with all your might and staying prepared for battle, even when you are experiencing no urges. Thanks, Pete. So I guess, in summation, we know that that there is a really high comorbidity between substance use and borderline personality disorder, much higher than for the general population. We know that the risks for suicide and self-harm and for misadventure are much higher when there's that comorbidity of self-harm, of substance use and borderline personality disorder. We know that working with the BPD is going to help reduce that substance use. And we know that DBT is a good treatment, and there's some easy adaptations. And I think things that people can bring into the work they're doing, even if you can't do a comprehensive DBT program, because obviously it's very resource intensive, there's still lots of, I think, principles and ideas that you can bring into the work that you do. Okay. And there's some references and links that we've included in there as well. And so at this point, I might hand back to Rebecca.
Thank you both very much. I actually do have a lot of questions, but I'm not sure we're going to get through them all. First one, for either one of you, is BPD more common in people that are more emotionally sensitive or empathic?
That's a good question. I guess we tend to think of the biosocial model as kind of, I guess, a synthesis of the biological and the social, and that there's an interaction and a transaction between these things. So it's not nature or nurture, it's nature and nurture. I think most of the people, we've got 455 participants presently here. Most of us are probably working in some kind of caring profession, and we're probably doing that because we have a high sensitivity to emotions, our own and others. With that comes a strong, usually, care and a sense of nurturance as well. And yet I'm guessing there are a few of us in the room who have BPD. So it's not that there is an inevitable consequence. An inevitable consequence of a high sensitivity is BPD. What that sensitivity does is it primes us for invalidation in our environment and to respond really intensely to that invalidation. So it's a bit of a vicious circle, a negative feedback loop. If somebody has a high sensitivity, they will enact an emotional response in a way that might be really quite profound. And if that emotional response is repeatedly met with insensitivity, with rejection, with validation, that will only heighten the distress that the person experiences, which only heightens the emotional and behavioural response, which only heightens the invalidation from the environment, in theory. So if that happens repeatedly, consistently enough, that has a very devastating effect on somebody's capacity to control their emotions, to understand their emotions, to feel safe within themselves, to feel secure within their relationships. It impedes their sense of trust in others, and it means that the person is kind of primed to have a very tough life. They're not well equipped to express their emotions and their needs. They're not very well equipped to express limits and boundaries about what they will and won't accept from other people. If that kind of happens, then you can expect a kind of pervasive emotional dysregulation, and that's in essence what we think of as BPD. Would you like to add anything further to that, Zoe? That's it. I hope that answers your question.
Thank you, Peter. Okay, this is a long one. If a diagnosis of BPD isn't made until the person is 21 or older due to hormonal teenage behaviour, coping with family dysfunction, life issues, substance use abuse, due to the fact that once a person has a diagnosis, then they get labelled, their behaviour may stem from addiction issues leading to emotional behaviour, and after they stop using drugs, their BPD behaviours may reduce or subside. Can we treat signs and symptoms without being diagnosed or labelled?
I'll have a go at that one. I think there's a lot of advantages to diagnosis, and at the same time, I think that stigma is real, and that people can have really awful experiences of having been labelled with borderline personality disorder. Mostly, I would say, from the health network, like from health services, as I don't think the general population really has an understanding of what borderline personality disorder means. And I think the benefits of diagnosis really come down to access to treatment. So, for example, here at Spectrum, you need that diagnosis to have access to, to DBT, for example. If you're in a setting that doesn't have those sort of stringent requirements, and you're able to just, treat people. I think that there's a lot of validity to the idea of a transdiagnostic approach, and DBT certainly is a transdiagnostic treatment, for example, that anyone who has difficulties with emotion regulation, whether that's at the severity of saying that they have borderline personality disorder or not, will benefit from DBT. And I think probably all of us would benefit from some of the skills of DBT, because we're all people and we all have emotions, and for all of us at times they get out of regulation. So it's a complicated one. I think that my own personal stance is to try and to not have the term BPD be so stigmatized, and then people, if you meet the criteria, then you meet the criteria, and it's not a pejorative term. But obviously it's a bit more complicated than that in the real world. Pete, I don't know if you wanted to add to that, otherwise I'll hand back to Rebecca.
Thank you. Is DBT recommended during a pregnancy with a mother with BPD and substance use?
I'll take that. Absolutely. I think that, sometimes we have clients within our DBT program here that are pregnant, and I think what a great opportunity to give somebody skills to be able to regulate their emotions before they embark on something that's going to be incredibly emotionally destabilizing, that for anyone requires, as many skills as they can. So, if they have that opportunity, I think that's fantastic. I don't think it's, there's any problems doing DBT whilst pregnant.
Thanks. Thanks, Zoe. How often do you think people get diagnosed with BPD when perhaps it's undiagnosed ADHD?
I don't have any hard and fast evidence or research that I've noticed with that, but anecdotally, I guess in my private practice, I'm seeing a few people with ADHD and autism spectrum type conditions and things like that. And there is definitely kind of on the Venn diagram, I guess, of symptoms between adult ADHD and youth ADHD, childhood ADHD. There is certainly some overlap, and I think we're becoming sort of increasingly more aware of the complexities here too. So it wouldn't surprise me that some people being misdiagnosed from time to time. It is, of course, possible to have both as well. So we know that there is a possibility of having very extreme emotional instability, but with some of the sort of signature symptoms of BPD, such as that sort of sense of emptiness and some of the kind of etiological conditions around experiences of trauma and invalidation too. So I think where ADHD exists, it becomes important to make sure that that component is being adequately supported, managed, treated with the person, a health professional. And it doesn't hurt to have at all, of course, somebody along the side encouraging and helping people to develop skills around emotional regulation and interpersonal efficacy. So I see these things as actually, in the end, in terms of treatment, there's a huge amount of complementarity. I may have gotten a little bit off track with your question. So just to sort of recap, I guess, I think it certainly is possible that some people are being misdiagnosed, but these are both capable of coexisting and kind of ramifying on each other. And there are sort of different treatment modes for each, of course.
Thank you, Peter. Next question, and we're certainly not going to get through them all, I'm afraid. DBT seems to give skills to help with regulating emotions, but not acknowledging the deeper issues. How does it deal with complex trauma rather than just surface presenting issues? Or is this a separate treatment model?
So great question. So I think, and certainly I haven't done DBT justice in my very brief little snapshot. So I think, and it certainly does have that, there's this idea out there that it is just about skills, and it's sort of not really taking into context, why people do the things that they do. And certainly that's not the case. I think what we know and like what the evidence shows us is that DBT is an incredibly effective treatment, and how effective it is correlated to how much people use the skills. So there is an emphasis on using skills, because that's the way that as a DBT clinician, I think people are going to be able to build that life worth living, so that they're not sort of constantly in crisis, that they're not feeling suicidal all the time. And then from that place, when they have that little bit of stability, that's a really great opportunity to do that deeper work. And sometimes people can do that within a year of DBT. I think it really just depends person to person. In terms of complex trauma, I think one of the symptoms of complex trauma is, intense emotional instability. And so DBT skills from that perspective are incredibly helpful. And we have lots of people that come through the program who, with that complex trauma diagnosis, that through doing DBT, they feel like that's enough and that they don't need to sort of do further work on their trauma at that time. Or maybe they'll go off and do that at a later date. But there are some people that they're not going to get much of a shift in their borderline personality disorder symptoms until that trauma is addressed, because the two are just too closely linked. And there are other protocols within DBT for that. So there's two different protocols. So there's DBT for prolonged exposure, and there's a DBT PTSD protocol. And without having time to sort of go into the details, basically there's a focus on exposure work within those models to try and really address the re-experiencing and the flashbacks, and it has really fantastic results, and it's something that we're starting to do more of at Spectrum, which is really exciting and I think long overdue.
Thank you. Now there's a few questions similar to this one. There seems to be a huge waiting list for DBT services or centres, especially through the public system. Are there any options for someone who is seeking DBT and feeling they are being rejected by other services, and particularly someone who can't afford private clinics or services?
I guess this is a presentation on DBT, but it should be clear that as well there are many different approaches to supporting people with the borderline personality disorder. And some of these will actually also have a positive impact on any concurrent substance use disorders as well. We know in an adult population, about 65% of people with BPD also have a severe substance use disorder. It's a really high rate. And so any kind of treatment for the BPD should have a positive impact on the substance use disorder. But I guess looking at your question specifically in terms of dialectical behaviour therapy and looking at it from a Victorian perspective, because I can't really speak for any other part of Australia, being a Spectrum and Victorian-based clinician, there isn't really a lot of sort of public funded support for accessing DBT other than using a mental health care plan, which, as we know, at best at the moment, you get 20 sessions. I mean, that's not nothing, but it's going to probably cover at best half of somebody's treatment. So accessibility is a huge issue. There are some services I'm aware of, which I'm not going to sort of seem to endorse by naming at this point in time, but you could call Spectrum to talk through any of the possible kind of referral entry points for a few services that do provide subsidised dialectical behaviour therapy or support people to access it around. There are a couple in Melbourne. So it isn't an impossibility, but it is a tall order looking to access treatment. And I guess this is a part of the problem, or the difficulty perhaps, with our publicly funded system or our mental health system more broadly is access. There's a huge demand for some very specialist and specific and effective treatments and not enough capacity and resources to meet those demands, unfortunately. So it is difficult, but it's not an impossible task. And with the Mental Health Royal Commission into Mental Health, we're looking at hopefully increasing funding and resources into the community. So there will be a trauma-based service being established at the end. I think it will open up by the end of next year, is my understanding, and hopefully that will provide greater opportunities for more people to access trauma-informed and trauma-based interventions to help people resolve things like their emotional dysregulation and things like that. So it's not a hopeless case. It's not quite as bleak as it might at first seem.
Thank you very much, Peter. Just to finish off, we've got a few questions around Spectrum specifically. Does Spectrum offer DBT training for professionals?
Yes, we do. So the calendar for next year should be up in a few months' time, just a couple of months. But we offer 2-day trainings. We've offered some shorter skills-focused trainings that we've been doing online. But there's always lots of DBT. It's always very popular. And absolutely, I really recommend people have a look at the website, sign up for the training calendar. But yes, we do.
Thank you so much. And final question, how do you accept referrals, or what's the referral protocol at Spectrum?
So we have an intake phone number. The eligibility criteria are that you need to be a Victorian resident, and a vast majority of, so people get referred to Spectrum for an assessment first and foremost. We're a statewide service with a very small number of people, and sort of rolling out and developing and delivering the treatment and support we offer. So unfortunately, again, our capacity to meet the demand isn't up to the task, because the demand is so huge. People can be referred by their GP under an item 271, thank you, for an assessment, but that assessment isn't a guarantee of accessing treatment, far from it. But most people who are referred for treatment and who are successful for treatment are referred by their area mental health service case manager. So we accept the people with the most severe expression of BPD and the most severe risks. So both the BPD itself and the risks attached to that. So risk of harm to self and or others. And so the way in then is to contact the intake phone number to talk through your concerns and talk through your request for an assessment, and how that assessment may come a referral, I guess a referral into one of our treatment teams, of which we have a few. We have dialectical behaviour therapy, we have mentalising based treatment, and we have an acceptance and commitment therapy stream as well.
Thank you very much. Thank you both so much for taking the time out of very busy schedules. And thank you to everyone for attending today. Again, please, if you can, use the QR code to complete the evaluation. And as mentioned earlier, Peter and Zoe are kindly going to share their slides, which will be forwarded to you via email. Thank you all. Have a great day.